Welcome to my YouTube channel. Today's topic is cerebral palsy. What is cerebral palsy? Cerebral palsy is a disorder of movement and posture that appears during infancy or early childhood, resulting from damage to the brain. The damage to the brain is permanent and cannot be cured, but the earlier we start with intervention, the more improvement can be made. Any non-progressive central nervous system injury occurring during the first 2, some says 5 years of life is considered to be a cerebral palsy. Time frame of brain injury. A diagnosis of CP is given if the brain damage arises during one of the following periods: prenatal period, conception to the onset of labor; perinatal period, 28 days intrauterine to 7 days; and postnatal period, first 2 and some says 5 years of life. After the age of 5, we speak of stroke or traumatic brain injury. Unfortunately, it is difficult to assess and clarify the prevalence and incidence rate of the disabilities in poor resource setting. Not only the prevalence of childhood disability is on the rise and CP is one of the costliest chronic condition, but also life expectancies are improving, which increase the burden of CP. For comparison, in the USA, there are approximately 7 lakhs children with CP, 2 to 5 per thousand born. Cerebral palsy is the most common motor disability in childhood. The etiology of cerebral palsy is very diverse and multifactorial. The causes are congenital, genetic, inflammatory, infection, anoxic, traumatic, and metabolic. The injuries to the developing brain may be prenatal, natal, or postnatal. As much as 75% to 80% of the cases are due to parental injuries, with less than 10% being due to the significant brain trauma or asphyxia. The most important risk factor seems to be prematurity and low birth weight, with risk of cerebral palsy increasing with decreasing gestational age and birth weight. The overall prevalence worldwide has increased during the last decades because of increased survival rates. There are some facts on the epidemiology of cerebral palsy. The incidence is 2 to 2.5 per 1,000 live births in Western countries. The prevalence varies between 1 to 5 per 1,000 babies in different countries. There are no reliable statistics from Asian countries. Some affected children do not survive. And etiology. Improved medical care has decreased the incidence of cerebral palsy among some children. Medical advances have also resulted in a survival of children who previously would have died at a young age. The type of cerebral palsy has also changed. In the 60s, Ethetoid dyskinetic cerebral palsy accounts for approximately 20% of children with cerebral palsy. Today, only 5 to 10% have this type, with spastic cerebral palsy now accounting for 80 to 90% of children with CP. This decrease is mainly due to advances in the treatment or hyperbilirubinemia. Bilirubin toxins to the cell that damage the brain. If a baby has severe jaundice, has a high risk of bilirubin passing into the brain, i.e. acute bilirubin encephalopathy. Promote treatment may prevent significant lasting damage. The increase of the spastic cerebral palsy is predominantly a result of a high survival rate for very small premature babies. The most common cause of cerebral palsy is idiopathic, which means that the cause of damage to the brain during pregnancy is not known. Risk factors. There are different risk factors for each stage at which a child might develop cerebral palsy. These can be broken down into prenatal, perinatal, and postnatal. Prenatal. Prematurity, gestational age less than 36 weeks, low birth weight less than 2500 grams, which could be due to poor nutritional status of the mother. Maternal epilepsy, hyperthyroidism, infections, severe toxemia or eclampsia, drug abuse, any trauma, multiple pregnancies, and placental insufficiency that are prenatal causes of cerebral palsy. Perinatal, premature rupture of membranes, prolonged and difficult labor, vaginal bleeding at the time of admission for labor, and bradycardia, that is called the decreased heart rate. Postnatal, 0 to 2 years, central nervous system infection, encephalitis or meningitis, hypoxia, seizures, coagulopathies, neonatal hyperbilirubinemia, and head trauma. Classification of cerebral palsy. The practice of classifying conditions such as cerebral palsy is important because it allows cases with similar characteristics to be grouped together. It is important to classify the different features of cerebral palsy as this helps to set realistic expectation and influences the treatment. Cerebral palsy is often classified based on several factors including severity, topographical distribution, which body part are affected, muscle tone, and functional ability of the child with cerebral palsy. Severity can be classified as mild, moderate, or severe. This classification is broad and lacks specific criteria, but it provides a simple way to communicating the scope of impairment. Topographical distribution refers to which part of the body are affected. It is a useful classification when combined with motor function classification, as it provides a description of how and where a person is affected by the cerebral palsy, which can guide treatment protocol. Muscle tone referred to the effect of cerebral palsy on muscle tone and how muscles work together. Two terms used to describe muscle tone are hypertonia, increased muscle tone, often resulting in very stiff limbs associated with spastic cerebral palsy, and hypotonia, decreased muscle tone, often resulting in loose floppy limbs associated with non-spastic cerebral palsy. A more recent development in the classification of cerebral palsy is the functional classification system, which focuses on the functional abilities of children in the domains of cognition, self-care, mobility, and social aspects. There are several classification systems within this, including the gross motor classification system, the manual ability classification system, and the communication functional classification system. These systems can be used by professionals and parents alike to observe different developmental areas and develop goals and interventions. The GMFCS is a widely used tool that has self-initiated movement in sitting, walking, and wheeled mobility. This system classifies children into 5 ordinal levels across 5 years band, which emphasizes on the child's typical performance in different settings. The age bands considered in the system are less than 2 years of age, 2 to 4 years, 4 to 6 years, 6 to 12 years, and 12 to 18 years. The level of distribution focuses on functional abilities and the use and the type of aids to achieve mobility. Subtypes of cerebral palsy. Anatomical classification are as following. Unilateral, one side of the body is affected. Bilateral, both sides of the body are affected. Spastic cerebral palsy is used to distinguish between quadriplegia, diplegia, and hemiplegia. Spastic cerebral palsy is either bilateral or unilateral. Dyskinetic cerebral palsy and atoxic cerebral palsy involve the whole body bilaterally. Spasticity. Spasticity is defined as an increase in the physiological resistance of muscle to passive motion. It is part of the upper motor neuron syndrome characterized by hyperphagia, clonus, extensor plantar response, and primitive reflexes. Spastic cerebral palsy is the most common form of cerebral palsy. Approximately 80% to 90% of children with cerebral palsy have spastic cerebral palsy. Spastic cerebral palsy is characterized by at least 2 of the following symptoms, which may be unilateral, hemiplegia, or bilateral. An abnormal pattern of posture or movement, increased tone, pathological reflexes, and pyramidal signs like Babinski response. Traditionally, we recognize three types of spastic cerebral palsy: hemiplegia, diplegia, or quadriplegia. Hemiplegia, unilateral. With hemiplegia, one side of the body is involved within the upper extremity, generally more affected than the lower. Seizure disorder, visual field deficit, tactile agnosia, and proprioceptive loss are likely. 20% of children with spastic cerebral palsy have hemiplegia. A focal traumatic vascular or infection lesion is the cause. It may be cases as unilateral brain infarct with post-hemorrhagic Parencephaly, cysts or cavities within the cerebral hemisphere can be seen on magnetic resonance imaging. Diplegia, that is bilaterally. With diplegia, the lower extremities are severely involved and the arms are mildly involved. Intelligence usually is normal and epilepsy is less common. 50% of the children with spastic cerebral palsy have diplegia. A history of prematurity is usual. Diplegia is becoming more common as more low birth weight babies survive. MRI reveals mild periventricular leukomalacia. Quadriplegia. With quadriplegia, all four limbs, the trunk and muscles that control the mouth, tongue and pharynx are involved. 30% of the children with spastic cerebral palsy have quadriplegia. More serious involvement of lower extremities is common in premature babies. Some have perinatal hypoxic ischemic encephalopathy. MRI reveals periventricular dysfunction. Dyskinetic cerebral palsy involved abnormal movement that occur when the child initiates movement are named dyskinesis, dysarthria, dysphagia, and drooling. Accompanying the motor problem, intellectual development is generally normal. However, severe dysarthria makes communication difficulties and leads the outside to think that the child has intellectual impairment, sensory neural hearing dysfunction, and impaired communication. Dyskinetic cerebral palsy accounts for approximately 10% to 15% of all cases of cerebral palsy. Hyperbilirubinemia or severe anoxia cause basal ganglion dysfunction and result in dyskinetic cerebral palsy. Dyskinetic cerebral palsy is characterized by the following symptoms: abnormal pattern of posture or movement and involuntary uncontrolled recurring, occasionally stereotype movement of affected body part. Dyskinetic cerebral palsy may be either dystonic cerebral palsy dominated by both hypokinesia and hypertonia, or chorioathetotic cerebral palsy dominated by both hyperkinesia and hypotonia. Ataxic cerebral palsy. Ataxia is loss of balance, coordination, and fine motor control. Ataxic children cannot coordinate their movement. They are hypotonic during the first 2 years of life. Muscle tone become normal and ataxia become apparent towards the age of 2 to 3 years. Children who can walk have a wide base gait and a mild intention tremors. Dexterity, the fine motor control is poor. Ataxic is associated with cerebral lesion. Ataxia is often combined with spastic diplegia. Most ataxic children can walk, but some need walkers. Ataxic cerebral palsy is characterized by the following symptoms: abnormal pattern of posture or movement, loss of orderly muscle coordination, so the movement are performed with abnormal force, rhythm, and accuracy. Mixed cerebral palsy. Children with the mixed cerebral palsy commonly have mild spasticity, dystonia, or athetoid movement. Ataxia may be component of the motor dysfunction in children in the group. Ataxia and spasticity often occur together. Spastic ataxic diplegia is the common mixed type that often is associated with hydrocephalus. Thank you for your time.